Okay, well, I'm Dr. Cowan. I'm one of the endocrinologists here at Georgetown, and I'm going to be talking to you guys about adrenal disorders today. If anyone has any questions, I guess at any point, we can wait till the end, or you can interrupt me, whatever you'd like.
Sometimes people will put comments in the chat, but I'll keep an eye out if there's any comments in the chat, and I'll let you know.
Okay, that would be good, because I don't know that I know how to see it.
Yeah, I got you. Don't worry.
Okay, I'm like the most technologically inept young person. Okay, so we're going to go through adrenal physiology, normal adrenal physiology, evaluation of the adrenal incidentaloma, and then we'll also talk about Cushing's, hyperaldosteronism, and pheochromocytoma today. So this is a picture of the adrenal gland. It sits right above the kidneys bilaterally. And then there's 3 layers of the adrenal gland. You might remember from like studying for like your steps in terms of the mnemonic for GFR. The glomerulosa is that's where the zonal glomerulosa is the outer layer. And this is of the cortex, the adrenal cortex that we're talking about. And that's where aldosterone is made. And that's like I think it's like salt. That's the salt mnemonic part of it. The fasciculata is also in the cortex. That's the middle layer of the cortex, and that's where cortisol is produced. And then the reticularis is the inner layer, and that's where androgens such as testosterone are produced. And then the adrenal medulla, which is inside the inner layer, even to the cortex, and that's where the catecholamines are produced. This is the adrenal steroid biosynthesis pathway. You do not need to know that. Like, our fellows need to know this, but this is just to show you that like it's kind of complicated. It's a steroid precursor, starts with cholesterol, and then by a series of enzymatic reactions, you make aldosterone, cortisol, DHT, testosterone, which is then converted to DHT, and estradiol. So you guys may have heard of the condition congenital adrenal hyperplasia, for example. In classic congenital adrenal hyperplasia, many of them lack either 17-alpha or the 21-alpha hydroxylase. And so if you don't have these steps, like if you don't have 21, for example, you can't convert from cholesterol to aldosterone. You can't convert to cortisol because you're missing this enzyme. And so so if you can't make these 2 things, everything is then shunted over to the sex steroid pathway. And that's why like female babies with congenital adrenal hyperplasia are virilized, and they have sometimes they have ambiguous genitalia that can look like male genitalia. So that means that this is complicated, but just know that there are a lot of enzymes that lead to the conversion from steroid to aldosterone, cortisol, and sex steroids. In endocrine, we all run on feedback loops. We love our feedback, our positive and negative feedback. So this is the hypothalamic-pituitary-adrenal axis. The hypothalamus produces corticotropin-releasing hormone, which acts on the pituitary gland, which then secretes ACTH, which then works on the adrenal gland and is responsible for cortisol production. Aldosterone, the adrenal gland also produces aldosterone. That is under more the Renin-Angiotensin system as opposed to ACTH control. Cortisol is the body's stress hormone. It helps maintain blood pressure and glucose. Aldosterone helps maintain blood pressure by stimulating salt retention, and not primarily mediated by aldosterone. So usually in our pathway, if you have cortisol production, that will feed back on the pituitary, and the pituitary will say, hey, okay, got enough cortisol production, I'm going to mitigate my ACTH production, and so I don't need as much cortisol. Whereas in Cushing's, for example, if you have a pituitary tumor that's secreting ACTH and that's the cause, you can have tons of cortisol, and it's going to feed back on the pituitary, and the pituitary should then stop producing ACTH, kind of shut it down. It's trying for negative feedback, but in something like Cushing's, for example, you lose that regulation. So you have high ACTH and high cortisol levels. The same would go for aldosterone. High aldosterone should feed back and should say, hey, I don't need any more aldosterone. But in hyperaldosteronism, you lose that feedback. This is the Renin-Angiotensin-Aldosterone System. And you have each step in the conversion, angiotensinogen to angiotensin 1 to 2 to aldosterone, and kind of where each thing acts. So this renin is responsible for the conversion of the first two steps. Then we have angioconverting enzyme, which catalyzes the reaction from angiotensin 1 to angiotensin 2. And so then you can see our treatments that are aimed at treating this condition, like ACE inhibitors, will thus inhibit this step here. Can you see my? I hope you can see my mouse. So this is where each thing blocks. So spironolactone and eplerenone, for example, those are those are aldosterone antagonists. So these are where our treatments are aimed in the pathway. Give me 1 second here. So aldosterone, again, principally controlled by the renin-angiotensin system through renin stimulation. It induces resorption, so you reabsorb sodium. So sodium in, potassium out. In the cortical collecting duct and distal nephron. The result of reabsorbing all that sodium is that you have extracellular fluid expansion, and that's responsible for the higher blood pressure. So in primary hyperaldosteronism, when you have too much aldosterone, you're going to have too much sodium retention. You're going to have increase in intravascular volume. That's where the hypertension comes from. And you have an increase in potassium excretion. So that's why in those primary hyperaldo patients, you often see a low potassium. Oh, okay. So too much aldosterone, low potassium, elevated blood pressure. Okay, so let's move on then to an adrenal incidentaloma. What is an adrenal incidentaloma? It's a mass greater than 1 centimeter in diameter. We often find these on autopsy, about 6%. We find on autopsy about 4% are found via CAT scan. The prevalence increases with age. In younger people, 20 to 29, the incidence or the prevalence is about 0.2%. And then in older people over 70, you see them in at least 7% of people. Causes of adrenal nodules. So we separate into those that produce hormones, hormone excess versus non-functioning adrenal incidentalomas. So in terms of those that produce hormones, you can see adrenal adenomas that produce cortisol or aldosterone. You can see adrenal cancer. Those can produce anything. Nothing is off limits for those. We often see a lot of the adrenal steroid precursors in those because they're very undifferentiated. You can have a pheochromocytoma, which is you see an increase in the medullary adrenal hormones, catecholamines in that, as well as metanephrines. Congenital adrenal hyperplasia, they often have adrenal nodules. Macronodular adrenal disease and nodular variant of Cushing's disease. Non-functioning, you can have lots of adrenal masses that are non-functioning. Myelolipomas, neuroblastomas, hemangiomas. You can have an adrenal cancer that's not functioning. Adrenal mets from other cancers, hemorrhage, cysts, infiltrative diseases, granulomatous diseases to the adrenal. In terms of adrenal malignancy, the prevalence is about 4.7% of primary adrenal carcinoma, and then metastatic disease to the adrenals, we see about 2.5% of the time. Malignant predictors, we look at the size and appearance. A big mass greater than 4 centimeters has a 90% sensitivity, but though a 24% specificity for the detection of cancer. We can see growth over time, and then we also look at the imaging phenotype, which we'll go over. Tumors that we often see metastasize to the adrenals, or if we're going to see a cancer with mets to the adrenals, it's usually lung, kidney, colon, breast, pancreas, liver, and stomach primary. So this is looking at imaging characteristics. It might be, I don't know how big it shows up on your screen, but with a pheochromocytoma, the key here is that they really brightly enhance when on contrast scans. They're always hyper-enhancing. They're often greater than 4 centimeters to be hormonally active. Like if you're testing labs and you see labs that are consistent with a Pheo, it's very unlikely to be less than 4 centimeters. They have to be pretty big to be that hormonally active. The Hounsfield unit, they're high Hounsfield units, greater than 10. And we'll also, my next slide is about this, with low washout at 10 minutes. So you can see here, this is an enhancing adrenal mass. A benign cortical adenoma, they're going to show up with like 10 or less Hounsfield units on non-contrast. And they're also going to have a high washout at 10 minutes. And so you can see here that this is not, brightly enhancing. Adrenal cancer, they're often big. They're going to have greater than 10 Hounsfield units, and they're going to also have low washout, and that's here. And you can see there's like areas of necrosis here in that. We'll get there. Okay. So, all right. So then this is looking at the imaging phenotype of adrenal masses. So think of the adrenocortical adenoma as a benign mass. So often small, but not always. They have smooth borders. They often look pretty. They're round, they're smooth. They're not they don't have areas of necrosis in them. They're kind of homogeneous in that respect. They're usually solitary and unilateral. So this is the less than 10 or greater than 10 Hounsfield units. So adrenal benign equals low Hounsfield units and high washout of contrast at 10 minutes. So greater than 50% washout. They're not highly vascular. They're often iso-intense in appearance in relation to the liver. They're usually stable over time where they grow very slowly. When we look at adrenal cancer, again, usually large, irregular with unclear margins. They're usually heterogeneous. They're not uniform appearing. Greater than 10 Hounsfield units, usually vascular, low washout, less than 50% at 10 minutes, and they're often hyper-intense in relation to the liver. You often see areas of necrosis, and you usually see rapid growth. A Pheo, usually greater than 3 to 4 centimeters, often nicely well demarcated with clear borders. They're heterogeneous. They often have cystic areas, high Hounsfield units, low washout, and they're very brightly enhancing. It's hard to mistake a Pheo. Usually slow growth. And then adrenal mets can vary in size. They often are irregular, unclear margins. They often look ugly. They're heterogeneous. They don't look kind of like an even color throughout. They also similarly have high Hounsfield units and low washout at 10 minutes, and they're often enhancing. So this is kind of a classic picture of adrenal cancer. So there's a big mass that shouldn't be here. And so you can see this mass, it's not super nicely round, it's kind of uneven, but you can see areas of necrosis in the mass here. And then you can actually see the adrenal cancer invading with vascular invasion. You can actually see it there. Here, looking at the other view, this is the adrenal cancer, and you can see that it's invading this vessel here. I once had a patient who he presented with unilateral gynecomastia in a 20-something-year-old guy, which is never normal. You think about the common things: is he abusing testosterone? Is he abusing some kind of steroid? By the time we found it, he had a 16-centimeter, that's huge, 16-centimeter adrenal mass. And by the time we got that adrenal mass out 3 months later, it was 27 centimeters. Adrenal cancer is often something that it's a lot like pancreatic cancer. When you find it, it tends to be very late in the course. It's not one of the cancers that you want to have. It's the survival, the survivability is not great for adrenal cancer. In contrast, this is here an adrenal myelolipoma. The attenuation of Hounsfield units is similar to that of subcutaneous or retroperitoneal fats. So here's an adrenal myelolipoma, this little thing right here, and then here is one as well. In terms of a follow-up, what do you do with these things? So the guidelines generally say we repeat recommended at 6, 12, and 24 months. To be honest with you, that's a lot of radiation for a patient. We usually just repeat it at, depending on how big it is. If it were really big, we might repeat it a little sooner, but I do 1 and 2 years personally for my patient. We do repeat the hormonal evaluation annually for at least 4 years when the initial hormonal evaluation is negative. The data there says that these adenomas do sometimes become functional later on if they're not initially functional. And so for those patients, if it's not functional at 4 years, it's very unlikely that it will be functional at that time. So let's talk about a case. These are all cases, my real cases, certain patients. So this is a 67-year-old female referred for consultation regarding bilateral adrenal masses that were caught on a CT chest that were done for shortness of breath. The answer on the boards in endocrine is like you never do imaging before you have biochemical confirmation. So on the boards, like you never image first. So this was done out of order, but it just happened to be caught on the chest CT. This lady has poorly controlled type 2 diabetes. She's on insulin. She has terrible peripheral edema. She's wheelchair bound. She's very obese. She's just puffy all over. She has like sort of weeping edema of the lower extremities. And she has easy bruising, and she can't stand. She has proximal muscle weakness. She couldn't stand up from her wheelchair if she tried. So on adrenal CT, we see diffuse multifocal nodularity of each adrenal gland. So you can see her adrenal glands are just like nodules. They're just lots of nodules together. The pre-contrast images were between 6 and 7 Hounsfield units, and the relative washout was compatible with a lipid-rich adenoma, i.e. greater than 50% at 10 minutes. So this lady had Cushing's. Cushing's, the most common cause of Cushing's is actually exogenous steroid, so prolonged exposure to excessive glucocorticoids, whether that's for asthma, COPD, transplant patients, and anything that requires a large amount of prednisone or other type of steroid. Endogenous Cushing's accounts for about 2 to 3, endogenous meaning their own overproduction of cortisol, 2 to 3 cases per million per year. There's a broad clinical spectrum. Many features are common in the general population. We'll go over that. So frequency of causes of Cushing's. So when we do see real endogenous Cushing's, most patients are ACTH dependent. Cushing's disease indicates a pituitary source, whereas Cushing's syndrome is the term we use for an adrenal source of Cushing's. About 68% of patients with Cushing's usually have a pituitary source, 12% with ectopic ACTH production. Ectopic CRH production is very rare. ACTH independent or adrenal causes, the benign adrenal adenoma is the most common cause, adrenal cancer, micronodular and macronodular hyperplasia, and then there is pseudo-Cushing's in cases of major depression or alcoholism, where it can look like they have Cushing's, but they don't actually have Cushing's. So this is to show that there's a lot of these are some of the presenting symptoms. So 82% of patients may present with muscle weakness, and then kind of in descending order, weight gain, high blood pressure, menstrual irregularities. In women, they're often quite hirsute, osteoporosis, low bone density, hypokalemia, psychiatric disorders. You can have steroid-induced psychosis for sure. We just had a case of that on the inpatient service. Easy bruising, diabetes, violaceous striae. We often think of like dark purple or dark red stretch marks. Only 44% of people present with that. So just because you don't have like dark red stretch marks doesn't mean you don't have Cushing's. Decreased libido, impaired cognition and memory. I also just want to point out these are presenting symptoms, but also just think about the number of patients that you have with each of these conditions or each of these concerns that doesn't have Cushing's. So that is to say that there's a lot of overlap in the general population as well. So these are all examples of patients with Cushing's syndrome or Cushing's disease and excessive cortisol. So you can see here she has a dorsocervical fat pad. We do not call it a buffalo hump anymore. We call it a dorsocervical fat pad. She has a lot of central obesity with very thin arms and thin legs. She's kind of got like a ruddy complexion, which is also very common. And then these are the types of stretch marks that are associated with Cushing's. So if they have like thin, kind of flesh-colored striae, that's not Cushing's usually. And it's usually not subtle. You can see here as well. This is another patient, and I often ask to like see their driver's license pictures, but this was this patient in 2001, and this is this patient in 2008 when he has Cushing's. You can see kind of the, he has got that rounded moon faces, and you can see his stretch marks. He's got a lot of stretch marks here, as well as like a small dorsocervical fat pad there. Oh, Oh wait, just kidding. That was not on your screen. This is on your screen. This is what I was just pointing to. And you can see here the central obesity as well, though his arms actually look pretty big. Okay, and so this is a child with Cushing's, and we can see the progression from this child at age 6, and then this was sort of a 4 or 5 year process, and you can just see how the appearance was changing. It's not subtle, but you can see the rounded faces. He keeps gaining weight, ruddy complexion, moon faces. Oh, then this is just to illustrate again the overlap in patients without Cushing's. Lethargy, depression. I mean, this is a common symptom in Cushing's, but it's also a common symptom of people in real life with 56% overlap. Irritability, decreased concentration, impaired short-term memory, hypertension. All of these things you can see in patients in the general population. We get a lot of patients in the endocrine clinic who are gaining weight, for example, and they think they have Cushing's because there has to be a reason other than like their lack of diet and exercise as to why they're gaining weight. So we do a lot of workups kind of for Cushing's, and it ends up being, these patients do not have Cushing's. They rarely do. It's a very rare disease, but that there just is a lot of overlap, and Dr. Google can be a dangerous thing because they read about it and think they have it. Who should be screened for Cushing's? Patients who have unusual features for their age, if they have multiple and progressive features. We don't treat kids, but children falling off the growth curve. Anyone with an adrenal incidentaloma should be screened for Cushing's. People who have sudden worsening of diabetes or hypertensive control. We do recommend against widespread testing. It's not cost effective. Diagnostic tests for Cushing's, thing to think about. History, physical, of course. And then we use 3 different tests, the late-night salivary cortisol, the 1 milligram overnight dex suppression test, and the 24-hour urine-free cortisol. So in the 24-hour urine-free cortisol, it's just what it sounds like. They gotta pee in a jug for 24 hours. This is a reliable index of cortisol secretion. It's not convenient. Patients don't like doing it. It's easier for men. Certainly they can just point and shoot, whereas women, it's actually really cumbersome to pee in a jug for 24 hours. So it should be greater than 3 times the upper limit of normal in patients with Cushing's. So actually in my patient, she had a normal 24-hour urine-free cortisol, which was unexpected, but it can happen. It's 2 out of 3. 2 out of 3 tests should be positive for Cushing's, I should mention. So then I was very surprised because this patient looked overtly Cushingoid. So I'm like, okay, I'll do a low-dose dex suppression test. So the idea behind this is if you take a milligram of dexamethasone at around 11 p.m. or midnight, and you measure the serum cortisol at 8 a.m. the next morning. And the idea there is if I give someone dexamethasone, their adrenal glands should be like, oh, cool, well, I have my steroid for the day, so I'm just gonna chill and not do anything because I don't need to do anything, right? So your own endogenous cortisol after you get dexamethasone should be quite low. That's my long-winded way of saying it should suppress endogenous ACTH and cortisol secretion to help you differentiate. So a normal level is less than 1.8. My patient had a cortisol level after DEX of 26.1, which is really high. I actually made her do it again because I didn't believe that she actually took the test. And she did it again and it was around the same. And she did take the dexamethasone. And then the last test that we use is the late night salivary cortisol levels. So the idea there is that in a normal subject, the cortisol levels are at their lowest, like in the evening, later in the day. So we do 11 p.m. to midnight, and I have them collect the sample on 3 different days between 11 p.m. and midnight. We really only need 2 levels, but they always mess up. So I just have them do 3 so they don't have to do it again. So the idea here is that the cortisol levels in the blood and in the saliva reach their peak around 8 a.m. So if I check the levels at midnight, they should be at their lowest. And so here in mild Cushing's, you can see you still have that diurnal variation, but your levels are overall higher. And then in severe Cushing's, you just lose all diurnal variation. You're just high all the time. So my patient, a normal value is less than 0.009. And so all 3 of her salivary cortisols were just floridly high. So then you have to think about establishing the cause, because we talked about ACTH independent and ACTH dependent. Is this pituitary or is this adrenal? So to do that, the ACTH level is what usually helps us with that. So if the ACTH level is high, greater than 20 usually, that's the pituitary source, ACTH dependent. And at that point, we're usually looking at doing an MRI to look for it. IPSS is inferior petrosal sinus sampling. If you can't find the MRI, if you can't find the adenoma on MRI, we would go ahead and do IPSS. It's very invasive. It only be done by like very experienced people. CRH tests and high dose DEX tests. You don't really need to know this for your purposes, but these are things that we would do in endocrine clinic if we needed to distinguish if we couldn't see it on an MRI. Suppressed ACTH means that it's an adrenal source, and then we're looking to image the adrenals via CT or MRI. Depending on what we see, if we see nothing, we might need to do adrenal vein sampling. That's more for aldosterone, not for cortisol. If it's cancer, we're working on that. The intermediate ACTH, there's a worldwide shortage of CRH, so we would do this test to determine whether it's pituitary or adrenal. I would say because there's a shortage of CRH and you can't get it anywhere, you're never going to see this. I would not worry about it. So treatment of Cushing's disease, the preferred treatment for Cushing's disease is get it out, take it out. And if it's a pituitary source, transphenoidal surgery to remove the pituitary adenoma is the answer. The initial cure rate is 75 to 90%. There's a pretty high recurrence rate of 5 to 20%. So the final cure rate of pituitary Cushing's is anywhere from 60 to 70%. The year after someone has surgery, whether it's adrenal or pituitary for Cushing's, is a pretty tough year for them. And the reason for that is because the hypothalamic-pituitary axis can take up to a year to recover. So think of it as like these people are used to having just huge amounts of cortisol circulating in their blood. And so then what a normal amount of circulating cortisol to them is going to feel like very, very little. So often these patients feel worse after the surgery than they do before it because they're just used to having so much steroid in their system. So the issue though is that for the adrenal glands to recover, they need to be allowed to wake up. So you need to be adrenally insufficient at least part of the day to allow recovery. So these patients often feel very fatigued. They often don't want to eat. They're weak and lethargic. They do often need stress dose steroids because their adrenal glands, because they've had these high doses of cortisol, their adrenal glands are sleeping. They're not doing anything. So they'll still need stress dose steroids. And the chronic effects of glucocorticoid excess may not disappear, such as hypertension, osteoporosis, diabetes. That often is not curative. Sometimes in these patients, we actually need to start them at super physiologic doses of hydrocortisone. Like we often, sometimes they might need, 50 milligrams twice a day of hydrocortisone, which is a lot, just to feel normal. And we often have to step them down so that we can get their own adrenals to wake up without having them feel so terrible. If surgery doesn't work, what do? Well, you go in again and you try for a second surgery. You can do pituitary irradiation. You can do medical therapy, which I'll get to. And then the last resort is bilateral adrenalectomy. You can't have Cushing's if you don't have adrenal glands to produce steroid. It's a last resort, but it is something that we've done it's something that we have done in the past and in the present. We just had a patient that we had to do it on in the inpatient service. So medical treatment of Cushing's, you guys don't really need to know the specifics. I more just bring this up. My fellows need to know, but you guys don't need to know. But I mostly bring this up to just show you that there are options for refractory Cushing's if you can't get all of it out on surgery. We use ketoconazole a lot. You guys might see that on the inpatient service. I don't think you guys will see meteropone or mitotane on the inpatient service, but you can inhibit, so steroidogenesis inhibitors inhibit the formation or the production of cortisol. Drugs that are aimed centrally at decreasing the ACTH secretion, octreotide, pasireotide, cabergoline. I don't see those used as much. A glucocorticoid antagonist that works at the level of the cortisol receptor, and it's mifepristone. And just the reason that that's interesting is that is also known as the morning after pill, and so you will not find it on formulary at Georgetown. So for our patients, and that's due to the religious leanings of the institution. So for our patients that we have needed mifepristone, they can get it at outpatient pharmacies anywhere but the Georgetown pharmacy. And in patients that we have really needed it, we've just ordered it from hospital center and they'll make an exception and bring it over. Optimal clinical recovery.
Could I ask a quick question about that? I thought, so for OB-GYN, they're able to do like IUDs and things as long as it's not for kind of contraception and those purposes. So I feel like this should be allowed since it's for a different goal.
So my understanding for OB-GYN is that they do the IUDs at hospital center, that they don't do them at Georgetown.
Certain providers will not do them at all. And certain providers will do them if you are doing it for like severe cramps or something of that sort, but not for contraception.
So they'll let them do it at Georgetown?
Hmm?
Oh, okay. Well, I know that, because I just remember, I don't know if they actually fill like for example, birth control. Last I had heard, they don't fill it at the Georgetown pharmacy, even if it is not for contraceptive purposes. So I think, so knowing that they won't fill birth control for non-contraceptive purposes at the Georgetown pharmacy, my guess is that they similarly wouldn't allow mifepristone. I know that they don't have it on the inpatient, like they don't have it inpatient, we have to get it from hospital center. So I don't know for sure, but my guess is that you'd probably have to get it from the
Okay, just interesting. Love Georgetown.
I mean, like the religious leanings of the institution, I prescribe birth control all the time. I use mifepristone. It doesn't affect how I practice medicine. Certainly I do what's right for the patient. I just tell the patient, you just can't fill it at the Georgetown pharmacy, but there's like a CVS right on Wisconsin if they happen to be here. So it doesn't affect how we practice, but just that, I guess I'll say, like, it's we have had to use it in certain inpatients with like super refractory Cushings, and like it takes like 2 days to come over from hospital center. So if you have a patient that you think you might need it, like, call us and we'll work on getting it ordered.
Okay, good to know. Thank you.
Okay, so I should mention, some of you guys have heard this lecture in the past, but for those who haven't, like, these are my patients when I practiced in like inner city Baltimore. And so the follow-up of these patients, unfortunately, was not ideal. So my patient, she was deemed a poor surgical candidate. So she had bilateral macronodular adrenal hyperplasia. So, what were we going to do? Remove both adrenals? I mean, we could have. But so she was not a good surgical candidate. She was very, very poor functional capacity, and she was terribly non-compliant. We were going to use mifepristone as a cortisol receptor antagonist. She ended up just refusing everything. We put her on Bactrim, which you often do in Cushing's patients because they're at increased risk for PJP. And then also, these Cushing's patients are also at risk for DVTs. And so we should think about prophylactically anticoagulating these patients. In the end, she refused all intervention and she didn't come back, which is somewhat dissatisfying, but that's what I would have done had she been compliant. But in better news, in our compliant patients, when you treat the Cushings, they get a lot better. And so this is the same patient, believe it or not, but this is a patient when she had Cushings, and then she had her surgery, and her Cushing's resolved, and then this is for now. Okay, so case number 2, another one of my Baltimore cases, is a 47-year-old male who's referred for persistent hypertension and hypokalemia. His potassium was 2.7 to 3.1 historically. He was really poorly compliant. We're sensing a pattern leading to multiple hospitalizations for hypertensive urgency and low potassium. When he did take his medication, the blood pressure was well controlled when he took metoprolol and amlodipine benazepril daily. Okay, so this gentleman had primary hyperaldosteronism, and this is, as we discussed before, autonomous production of aldosterone, which leads to suppression of plasma renin, and it leads to sodium retention, salt in, potassium out, hypokalemia, and hypertension. Why do we care? So this is actually really common and really underdiagnosed. So 5 to 10% of patients, of hypertensive patients, actually have this condition, and 20% of those patients with drug-resistant hypertension have hyperaldosteronism. So we need to think about testing more people for this. Hyperaldosteronism in and of itself has adverse cardiovascular and renal effects, including increased carotid intima media thickness, reduced endothelial function, and increased inflammatory markers. And even in these patients with primary hyperaldo with well-controlled blood pressures, they have worse cardiovascular outcomes with the same degree of blood pressure control than people without hyperaldo. Who should be screened? Anyone with an adrenal nodule, anyone with moderate or severe hypertension. So this is anyone with systolic blood pressure over 160, resistant hypertension, 140/90 on 3 medications, hypertension with spontaneous or diuretic-induced hypokalemia. If they have family history of early onset hypertension or CVA, at usually less than 40, or if they have hypertensive first-degree relatives, which actually is a lot of people. So our main screening tool here is the aldo to renin ratio. An aldo-renin ratio greater than 30 is pretty much slam dunk for primary hyperaldosteronism. Less than 20, I feel like less than 15 is unlikely. We usually see primary hyperaldosteronism, usually the aldo is greater than 15. This lab should be done at 8 a.m. fasting. So if you're gonna check this in your patients, you just really need to know how to check it. We do 8 a.m. fasting, and like not even, we have them take their meds after, like we don't even want a sip of water. If you think about it, anything that increases intravascular volume, such as water, or anything like that increases salt, because we often see patients get this done like afternoon after they've eaten. So if you have a big salt load, that's going to decrease the plasma renin. If you have a big volume load, that's going to decrease the plasma renin. And anything that decreases the plasma renin is going to make that ratio look abnormal. So I've had patients with aldo-renin ratios of 50. They don't have hyperaldosteronism. The diagnosis is they ate French fries before they had their labs drawn. So it's important that they get it drawn under ideal conditions. So screening, correct hypokalemia, you want to have this done when the potassium is normal. Meds that should be withdrawn, so this is actually kind of controversial in our world right now. The guidelines will say withdraw spironolactone, eplerenone, amiloride, triamterene, potassium wasting diuretics for at least 4 weeks before you do it. And they say usually okay, but you can withdraw for 2 weeks. Beta blocker, ACE inhibitor, ARB, alpha-2 agonists, and calcium channel blockers. So more recently, our experts in the field are saying, let's just do the aldo-renin ratio. And if, for example, if an aldo-renin ratio on spironolactone or eplerenone shows primary hyperaldo, it's primary hyperaldo. Because the concern is that if they're on spiro, that the ratio might not be as high as you might expect. So there is some controversy in that field, but what I do right now, like how I've kind of taken the guidelines and the more recent expert advice, is I've kind of merged it. So in my practice, I generally don't, I hope you guys can see my mouse, I generally don't withdraw these drugs. I do it on these drugs. I do it on potassium wasting diuretics too. I'll do hydrochlorothiazide, I'll do chlorthalidone. I'll just make sure that their potassium is normal. The big thing I would say is just take them off these, the spiro, eplerenone, amiloride, triamterene. You see those for at least 4 weeks and then do it. So generally I'll do that and then I'll keep the other meds on. If the aldo-renin ratio, if I'm expecting to see primary hyperaldo, for example, and the aldo-renin ratio is not what I'm expecting to see, it's not slam dunk, then I might withdraw the offending meds and then recheck it at that time. But usually primary hyperaldo on these meds will show even if you're on these meds. When we think about which medications do not interfere with this, like if I'm going to take them off the meds, what do I want them on? These are the medications that we use in primary hyperaldo to do the testing: verapamil, hydralazine, and then terazosin, prazosin, and doxazocin are what we'll use. Those are like the safe medications by the book to do the testing on. So this is our little algorithm here: primary hyperaldosteronism. So hypertension and or hypokalemia, you screen with an aldo-renin ratio. It is important that they need to be upright. Ideally, they'd be upright at least 2 hours before they have the test. You want them at their most dehydrated. I tell them, people don't really want to wake up at 6. I tell them go in, be upright for at least an hour. You don't have to be up and moving around, but you need to actually be sitting up in bed. We don't want people to like roll out of bed and go to the lab. You can do confirmatory testing. via saline suppression test or oral salt loading test. This is also now a step that we're tending often to skip if it's like a slam dunk case of hyperaldo, aldo-renin ratio shows it, they've got spontaneous hypokalemia. We sometimes will actually skip this step and go right to the adrenal CT scan. That's kind of more recent that we're doing that. So then let's say you've got an adrenal CT scan, it shows an adenoma. Then the next step is, do they want surgery or do they not want surgery? If they don't want surgery, we treat with a mineralocorticoid antagonist like spironolactone or eplerenone. If they do desire surgery, depending on their age, we will do adrenal vein sampling. In younger patients less than 40, because the incidence of adrenal adenomas is very low, generally in those patients, if they've got an adenoma, you can just go take out that adenoma. In older patients, the incidence of adrenal adenomas is much higher. So sometimes we'll see an adenoma on one side, but the aldosterone will be coming from the other side. So in these patients, we do pursue adrenal vein sampling. Okay. So our patient, this patient of mine, he had an aldosterone level of 40.2 with a suppressed renin of 0.2. Remember, he was on the ACE inhibitor. He was on, sorry about this. He was on amlodipine, he was on an ACE inhibitor, and he was on a beta blocker. And even with all of those things, it was a slam dunk case of hyperaldo. His aldosterone renin ratio was 201. I also, because he had an adrenal adenoma, you would know that we need to do the Cushing's test as well for any adrenal adenoma. In an adrenal adenoma, the best test for Cushing's is the dexamethasone suppression test. And we would want to rule out co-secretion because we often do see tumors co-secreting both aldosterone and cortisol. So he did not have a co-secreting tumor. So for him, I didn't do confirmatory testing. This was just such a high ratio, and it was such a setup, a good story for hyperaldo that I skipped the confirmatory testing. I didn't feel like I needed to confirm it. I did a CT of the adrenal gland. It showed minimal thickening of the inferior lateral limb of the left adrenal gland that may represent an adenoma. I actually went down to talk with the radiologist, and he was like, if you weren't standing over me right now, I would never have called this. But because we're looking for something, I might call it that. So he's like, if you're twisting my arm, and the washout percentage was compatible with a benign adenoma. It was less than 10 Hounsfield units. So this is not, that is to say that on CT, it's not really localizing. We can't be sure of where the source is. So this is a case that you would need adrenal vein sampling for to localize which side the hormonal excess is coming from. But the first step is, even before we do adrenal vein sampling, is do they want surgery or do they not want surgery? The surgical management of hyperaldo is you take out the diseased adrenal, unilateral laparoscopic adrenalectomy. About 1/3 are cured, 1/3 are improved, and 1/3 there's no difference. Hypertension is cured in about 50% of patients. The max improvement that we see in blood pressure is usually 1 to 6 months after the surgery, but can take up to a year. Factors predicting cure. If their hypertension is not as severe at baseline, they're using 2 or less antihypertensives. If they have less than 1 first-degree relative with hypertension, the shorter time they've had hypertension, less than 5 years, is associated with a better response to surgery and or a good response to spironolactone preoperatively. Medical treatment. So spironolactone usually start at 25 milligrams twice a day. It can be titrated up to huge amounts, up to 400 milligrams per day for hyperaldo. The right amount of spiro is the amount it takes to control their blood pressure. In men, one of the side effects is gynecomastia, unfortunately, which often limits our use. Decreased libido. Women can have menstrual irregularities and men can have erectile dysfunction. Eplerenone is a little bit more specific. It can be titrated up to 200 milligrams per day. More selective inhibition at the receptor level. One might say, well, why don't you just use eplerenone for everyone? And the answer to that is it's expensive and sometimes not covered by insurance. Okay, so going back to our gentleman, so we're here, we're at the adrenal CT scan level, and then he did desire surgery. So we went ahead and we did the adrenal vein sampling. They take a catheter up to the groin, and they catheterize the adrenal veins at both sides, and they look for the which side lateralizes the excess of aldosterone. So our gentleman underwent ABS, and it showed lateralization of the hyperaldo to the left adrenal gland. However, there was also evidence of overexcretion to a lesser extent in the right adrenal gland, indicating that he had bilateral adrenal hyperplasia. We gave him the options for a left adrenalectomy because that was the more diseased gland versus management with an aldosterone antagonist. So we thought that at least by taking out the much more diseased gland that we could see some improvement in his hypertension and hypokalemia. And so this was Baltimore, there's lots of compliant patients in Baltimore. This was not one of them. And so I don't actually, we offered these, he was a truck driver. I think he moved and we didn't end up being able to follow up with him. If I were in his position, I would have gone for the left adrenalectomy because the numbers were a lot more pronounced on the left side. Case 3, so this is one of my compliant patients. This is a 58-year-old man with a history of hypertension and atrial fibrillation with refractory palpitations following an ablation for atrial fibrillation. He had episodes, so after he had the ablation, he had episodes that felt like AFib, but they weren't confirmed on monitoring. Like he would wear a monitor, a Holter, and he was having these episodes, but he wasn't having runs of AFib. He would have these episodes of sweating and his head was pounding and he'd get really pale and lightheaded. He did not have panic attacks or a feeling of impending doom. He was on metoprolol and flecainide, and his cardiologist was a very astute guy, and he suspected there was something more to this story. It's not, so it's not often that you get a referral for a confirmed Pheo from a cardiologist. I was just really impressed because the cardiologist actually did the workup and sent him to me with high levels, so it was pretty cool. So pheocytoma or paraganglioma, these are catecholamine secreting tumors. Generally 80 to 85% of them are. You can see increases in epinephrine, norepinephrine, dopamine, and these arise from the chromaffin cells of the adrenal medulla. Paragangliomas are 15 to 20% of these tumors, and those arise from extra-adrenal chromaffin cells. So you often see those in like the neck, for example. In general, hypertension clinics, 0.2 to 0.6% of patients, and they account for about 5% of adrenal incidentalomas. Clinical signs and symptoms, so the classic ones we think about, sweating, palpitations, tachycardia. Hypertension, these patients are really usually hypertensive. Headache, nausea, various things. And then you get into, with the lesser ones, like these are things that a lot of people have, hyperglycemia, nausea, flushing. It's actually not a lot. But that anxiety, a lot of them have panic attacks. But that is to say, like, not anxiety is a very prevalent condition these days, especially, well, even pre-COVID. And so I get a lot of patients who have panic attacks that end up being tested for this, but they don't have this very rare condition. So who to screen for Pheo? Anyone with adrenal incidentaloma, with or without hypertension. Signs and symptoms of Pheo: familial syndrome predisposing them to Pheo. We see this in MEN, neurofibromatosis, and von Hippel-Lindau, and anyone with a family history of Pheo. Biochemical testing, plasma-free metanephrines. If you have a high index of suspicion, this is a very sensitive test, but the specificity is not as high in the blood levels. Urinary fraction, this is the 24-hour urine fractionated metanephrines. That's if you have a low index of suspicion. Greater than 4 to 5 times the upper limit of normal is considered abnormal. In patients, I will say too, like in patients who I really think have a high index of suspicion, of course, I'll draw the blood levels. A lot of people don't like doing 24-hour urine tests. So like in patients who I have a low suspicion for, I would usually order a 24-hour urine test. But if I just get this feeling that they're not going to do it, in those cases, I will just draw the blood because I'd rather have a result than not have a result. So this patient, he had elevated everything. His norepinephrines were 630, just a little bit high. Metanephrines 2470, that's far greater than 5 times the upper limit of normal. Normetanephrines were a little bit high. Metanephrines very high in the plasma. I ended up doing both. He got both done. So important to take into account when you're doing testing for Pheo, if you're doing this in your clinic, things that can cause false positives. Tylenol is a big one, labetalol or sotalol, methyl dopa, tricyclic antidepressants. buspirone, phenoxy, MAOIs, levodopa, and sulfasalazine. Tylenol is the most common one I see. I say don't take your Tylenol. Also like Ritalin, that kind of stuff, you should have them stop as well. So in terms of his imaging, his initial imaging, it was a hyperintense mass, but it shows a pre-contrast Hounsfield units greater than 10. Washout time was less than 50%. On MIVG, that's a compound resembling norepi that's taken up by adrenergic tissue. We don't use this as much, only if we suspect like a metastatic Pheo or a metastatic paraganglioma. Or if you know someone has a Pheo, or you know someone has abnormal lab but it's not showing up on CT or MRI of the adrenal glands, we'll use that. And then oftentimes a PET scan in metastatic cases. So my patient had a 3.3 centimeter mass in the right adrenal gland, Hounsfield units of 36 to 100 with a low washout. So then the question is, do you screen? This guy has a unilateral Pheo, to screen or not to screen for genetic disorders. So when to screen for a genetic disorder causing Pheo, if they have a positive family history, if they're young, they're less than 45, syndromic features like something that might indicate neurofibromatosis, if they have cafe au lait spots, other features of MEN1, hyperparathyroidism, for example. If you have multifocal or bilateral Pheos, anyone with a paraganglioma should be screened if you have metastatic disease or skull base and neck involvement. Perioperative medical management, alpha blockade, alpha blockade, alpha blockade for 7 to 14 days preoperatively. We usually use phenoxybenzamine or doxazosin or another alpha blocker. Phenoxy is often really expensive and it's hard to get on, especially the Medicaid and Medicare plans. It can be hard to get. If you'll recall, this gentleman, he was on an unopposed beta blockade, which can be really dangerous in Pheo patients. So I started him on an alpha blocker like immediately when I found out he had a Pheo. But so alpha blockade 7 to 14 days prior, and then a beta blocker only after 3 to 4 days of appropriate alpha blockade. And we'll often use propranolol or atenolol in that case. If they're alpha blocked, beta blocked, and they still have issues with blood pressure, or calcium channel blocker would be fine. We titrate the alpha blocker to orthostasis. Like if they feel like crap and like they're gonna faint, that means you're doing a good job. And so we ask them to have a high salt diet and liberalize their fluid intake just to keep their intravascular volume up. Surgical management. So generally 6 centimeters is the cutoff for laparoscopic versus open resection. Paraganglioma is always open. These are like really difficult surgeries. There's often like huge blood pressure swings intraoperatively. When you manipulate the tumor itself, you get like huge releases of catecholamine, and so they can be very difficult to do. It's, we have very good surgeons at Georgetown. Post-operatively, they can develop hypotension, rebound hypertension, or hypoglycemia. So these are all things that we monitor for post-operatively. My most compliant patient, who is still my patient, who followed me from Baltimore, he's a good guy. So we alpha blocked him immediately. He had an uneventful laparoscopic right adrenalectomy. He's off everything. He's off all antihypertensives. He's a really happy guy, asymptomatic. He came off the flecainide because he didn't have AFib, and I just screen him now once a year. And the recommendation is you screen once a year for the metanephrines and the normetanephrines and the catecholamines after resection of a Pheo or paraganglioma. So in conclusion, we reviewed adrenal gland physiology. We talked about adrenal incidentalomas. For your board exam, biochemical workup for hormonal excess should always precede imaging. And then we discussed that incidentalomas should always be evaluated for hormonal excess. And we talked about Cushing's, hyperaldo, and Pheo.